is a scientist from Genentech, and she's credited with one of the first studies investigating IO and VEGF targeted agent with atezolizumab and bevacizumab in metastatic renal cell. We all remember the elegant study of Dave McDermott and colleagues. Now, launching this, the first talk is going to deal with genomic DNA and RNA biomarker. We're going to have our good friend, surgeon scientist from Memorial Sloan Kettering, Ari Hakimi. If the reason to be 7 in the morning is that he's a surgeon, so you can blame him.
Good morning, everyone. Thank you. Okay, so my disclosures. So good morning, everyone. So I was tasked with a 10-minute challenge of trying to sum up biomarkers in the last 10 years or so. And I'm going to focus on just kind of a quick summary of what where we're at now. And obviously, a lot of people here will be talking about where we're going. So in terms of mutational biomarkers, I would just highlight a lot of the work that's been done, just kind of predicting which patients will recur, which is primarily the value of that, and really comes down to the common recurrent mutations in RCC. We've all my group, and as well, of course, as Jim Bergarolas has demonstrated the value of BAP1 mutations in predicting recurrences and metastatic disease. And this has been shown both with mutations and by IHC in large studies now. So it's pretty established that BAP1 mutated RCCs in particular are likely to recur much more than others. And we've and others have tried to utilize them into different clinical scenarios and adjust for our best kind of predictors by clinical pathologic features, including the Mayo Clinic S-sign score, or other scores that incorporate stage and grade and necrosis and other features that we know are prognostic. And there's marginally additional value in knowing the mutation status of those tumors. I would say that mutations are informative, but don't really guide any sort of other therapies here. In terms of how they've been integrated in the metastatic setting, the first work from our group also looked at them in the context of VEGF therapies, where we utilized in the first line setting for VEGF, which is obviously no longer utilized much, but integrating common mutations such as BAP1, PBRM1, and P53, showing some maybe additional value to stratify patients within the different IMDC or MSK risk groups. But again, of limited clinical value, maybe a little bit more discrimination on the margins. TMB has been looked at, of course, as a predictor for immunotherapy response. In many other cancers, it is quite effective, and you can stratify patients by median or by quartile, or even just having hard and fast numbers that are associated, and obviously FDA labels for certain cancers. But TMB has not been one of the ones that has been useful in clear cell renal cell carcinomas. Dr. McDermott, who's here, has shown this. It's been shown in Javelin, and of course by David Braun in his Nature Medicine paper on combining a lot of the BMS trials. There's really limited to no value, and it's in one of those cancers where we see a tremendous amount of T-cell infiltrate, but it's not clearly linked to a mutational burden. PBRM1 has been potentially utilized as a biomarker for IO response, and I think there are probably more nuance to this. The initial paper from Tony's group and Dana-Farber suggested that PBRM1 might be a predictor for first-line nivolumab, and subsequent work from David and others has suggested that as well. Both our group and the MD Anderson group did not see as much of a signal in the first-line setting. However, there's probably, it's more complex than simple PBRM1 alone, and if you would incorporate PBRM1 in the context of other common chromosomal events, such as 9p loss, we see clear differences in immune infiltration patterns. And I think it's safe to say that PBRM1 is strongly associated with His signaling, and then there may be a further interplay between PBRM1 and other genomic events that may lead to prognostic and potentially predictive phenotypes. So overall, I would say this is a summary that we had published where we looked across cancers using the MSK impact from about, I think at the time, about 40,000 patients. And we looked at the value of mutations in terms of predicting therapies. And I just wanted to highlight RCCs on the bottom there in terms of druggable targets. So most of the mutations that I've described here are really just giving you a sense of prognosis, and they're not predictive of any sort of therapeutic value in clear cell renal cell carcinoma, at least. So it's really on par with what you might see in pancreatic or prostate, obviously excluding AR. So the notion that a mutation would guide treatment is very limited in our field. And some of the value of doing just broad mutation profiling in everyone that comes in has been limited. And we certainly pulled back from that strategy, in clear cell at least. In terms of RNA, so I think this is, again, you can split this into prognostic, but now potentially predictive. There are, I think, three prognostic markers that I like that have been kind of published and then vetted and reconfirmed by others. So of course, Kim Rathmel developed their ClearCode 34, initially called CCA-CCB. And that was really just actually an early foray into understanding the notion of angiogenesis and myeloid features. If you actually go back and look at the initial classification scheme of CCA and CCB, CCA is really picking up the angiogenically high tumors, and CCB is really picking up the myeloid high tumors. And then there's the cell cycle progression score, which is really just more of a picking up kind of a cycling or aggressive tumors, and a 16 gene recurrence score that was also came out. That one I have not seen externally validated yet, but it was a very large study. And then of course, we'll talk about the RNA signatures for the microenvironment, but those are sort of the ones that have been utilized. Again, adding a little bit of a benefit for above the nomograms that we currently use for prediction. So maybe a little bit of additional value in the adjuvant space to really identify the highest risk patients. But again, I would say these are of limited value overall. So of course, we have now biomarkers RNA level that may help kind of guide treatment. And I think people like Brian Rennie and others are developing trials around these concepts. But I think the first one that really has shown a lot of value is angiogenesis. And of course, Dave McDermott's work and our work on the COMPARES trial demonstrated that angiogenesis is associated with VEGF response. Angiogenic tumors in general have more PBRM1 mutations. I think a lot of folks have shown that. And they tend to have a less aggressive course overall. If you look at highly angiogenic tumors in the context of localized disease, they tend to recur less. They tend to be better tumors overall. And they're of course very predictive of anti-VEGF response. T effector and Javelin 101, I would put them together only because they're capturing sort of a broad a range of T cell phenotypes, and they are associated with improvement in ICB. Although I would say that they've been shown in the individual trials for which they were developed. When you apply them to additional trials, which again have not been done on large scales, there is a potential improvement in terms of response. And again, on the up here, I show that our work in single cell data to kind of show that what they're capturing is really not just a single population of T cells, but rather either a state or many T cell populations that are being reflected by these biomarkers. So they were developed initially to look at patients that did well versus not, using kind of unbiased RNA approaches. But what they're really capturing is, you might say, a state in the immune system rather than a specific population. So that's obviously both a challenge and a benefit of these. Finally, I would just talk about TAMS and the myeloid. So again, this is not a specific population, but these scores that were developed initially by Genentech, and then others have kind of applied or focused using either single cell or other RNA-based approaches to understand a myeloid response. And again, this is capturing really more than just one thing. It's capturing macrophage state, usually neutrophil state. And others have shown specific values of specific macrophage populations, and whether you can develop signatures based on those from single cell data or others is still yet to be seen. But clearly, they are very valuable. And I think one thing I would point out that's exciting is that one of the work that our fellow published last year in Cancer Discovery was that these myeloid responses or somewhat version of that called the MSK inflammatory signature were very predictive of recurrences. And they're actually capturing also an adenosine high state, which is potentially target. So we showed in this work and validated across other data sets that above beyond any of the nomograms, if you're a myeloid high tumor, you're much more likely to recur and potentially could be targeted by these adenosine inhibitors. So there's potential value for some of these beyond just prognostic and could be predictive of potential responses. I think that's where the field might be going in an exciting fashion. And of course, I would be remiss if I didn't talk about how people are trying to integrate these two concepts of both mutations and these angiogenic and myeloid states, and work from Genentech, of course, and from Bob and others have shown that some of the mutations are more likely to occur in the context of these different immunologic states, including, of course, PBM1 and the angiogenic ones, but BAP1 also may be associated with more of an inflammatory state, which Jim Bergolis has shown in beautiful studies as well. So there's probably some sort of integration you could do, but I don't think it's going to add much more predictive value here or prognostic value, but it certainly understands the biology as well as what's driving these states. So in conclusion, DNA is largely prognostic in CCRCC. RNA signatures have been both prognostic and potentially predictive, although again, they remain to be externally validated in other data sets. There may be some obviously opportunities to utilize biomarkers for further therapeutic consequences. And of course, we need to do more work. So thank you very much for your time. Questions at the end?
Good morning, everyone. So I'm Maria Kusini from Genentech, and I'm happy to introduce our next speaker, Sabina Signoretti, who's going to take us, who's going to review for us multi-parametric immunofluorescence, specifically spatial biomarkers, tissue-based in situ analysis, including IF for biomarker development.
Thank you very much for the nice introduction. So today it's really a great pleasure to present some of the work that we have performed in the lab in the past few years in trying to understand, to use in situ analysis to develop biomarkers for immune checkpoint inhibitors in renal cell carcinoma. And so I am completely inept in doing this. So how do I advance forward? Oh, there you go, back. All right, my presentation here today is gonna be focusing on results of in situ analysis using multiplex immunofluorescence in paraffin-embedded tissues. And this technology is particularly well suited for hypothesis-driven biomarker research in relatively large patient cohorts. And we like this technology also because we believe it has a relatively good potential for clinical test development because it has already been implemented in some CLIA certified pathology laboratories in the US. So having said that, several years ago, we decided to develop biomarkers for anti-PD-1 therapy in CCRCC by looking at components of the tumor microenvironment. And we decided to start by investigating inhibitory receptors on CD8 positive effector T cells. And the receptors that we decided to analyze included PD-1, and this was an obvious choice because PD-1 is the target of the therapy, but also TIM3 and LAG3. And these were chosen because TIM3 and LAG3 have been shown to be co-expressed together with the PD-1 on terminally exhausted effector T cells, and they have been implicated in resistance to anti-PD-1 therapy. So to quantify the expression of PD-1, TIM3, and LAG3 in CD8 positive TILs in clinical trial tissue samples, we developed and implemented a robust multiplex IF assay. And so through this work that actually spanned a few years, we were able to demonstrate that high levels of CD8 positive tumor infiltrating cells that express PD-1, but not TIM3 or LAG3, are associated with improved responses and also improved PFS on nivolumab, either alone or in combination with PD-L1 in 3 independent clinical trial cohorts. And in fact, these associations were initially detected in the CheckMate 010 trial, then independently validated in the CheckMate 025 trial, and more recently further validated in the HCRN GU16260 trial led by Dr. Atkins that evaluated nivolumab in the frontline setting. So these results are not only highly reproducible among different clinical trials, but they also make sense biologically. And this is because the CD8 positive cells that express PD-1, but not additional inhibitory receptors, are thought to represent antigen experience and non-terminally exhausted T cells that are only mildly dysfunctional and can be then rejuvenated by the anti-PD-1 monotherapy. So having identified this immune cell population that is linked to a response, then our more recent efforts have been directed to identify immune cell population that are associated with resistance, with the final goal of developing a more robust multi-marker model. And so we became interested in regulatory T cells because of recent very elegant work from Arlene Sharp and Gordon Freeman that demonstrated that PD-1 signaling in regulatory T cells inhibits their immune suppressive activity. And we became really intrigued by these results because of their potential significance for patients treated with anti-PD-1 therapy, because they suggest that PD-1 blockade on Tregs in the tumor microenvironment may make these cells more immune suppressive and therefore limit the activity of anti-PD-1 therapy. So for these reasons, we developed a multiplex IF assay to specifically detect the PD-1 in the Tregs in the tumor microenvironment in tissue samples from the CheckMate 025 trial to test the hypothesis that high PD-1 expression on Tregs would be associated with resistance to PD-1 monotherapy in ccRCC. And so, to make a very long, short story, extremely short, maybe too short, in line with this hypothesis, we were able to demonstrate that high percentage of PD-1 tumor infiltrating Tregs is associated with the shorter PFS, shorter OS, and lower response rates in nivolumab treated patients, but not in everolimus treated patients. And so, taken together these results that I just briefly summarized for you today, this body of work suggests a model in which PD-1 blockade on Tregs and PD-1 blockade on non-terminally exhausted CD8 positive cells really have opposite effects on tumor growth. And in fact, blocking PD-1 on Tregs renders these cells more immune suppressive and therefore drives tumor progression, while blocking PD-1 on the CD8 positive effector T cells render these cells more effective in anti-tumor immunity and leads to tumor progression. And as you can imagine, these the data have an important clinical significance because they suggest that targeted Tregs may actually synergize with PD-1 inhibition in patients with the ccRCC and imply that clinical trials that test the combination anti-PD-1 with the Treg depleting agents should be prioritized for this patient population. Now, since this is a biomarker symposium, from a biomarker standpoint, since the PD-1 expression on the Tregs and PD-1 expression on the CD8 positive effector T cells are associated with opposite clinical outcomes, it can be hypothesized that an integrated biomarker that takes into consideration PD-1 expression in both these T cell subsets can actually predict responses or resistance more effectively. And so one way of developing such a biomarker is by calculating the ratio of the percentage of Tregs that express PD-1 and the percentage of CD8 positive cells that express PD-1, but not in 3 and LAG3. I'm going to refer to this ratio as PD-1 ratio. So in this scenario, you can imagine that a tumor with high PD-1 ratio would be characterized by relatively high levels of expression of PD-1 on the Tregs and relatively low levels of PD-1 expression on the CD8 positive cells. And therefore, this tumor would be resistant to the therapy. In contrast, a tumor with a low PD-1 ratio would be characterized by relatively low levels of expression of PD-1 on the Tregs and relatively high levels of PD-1 expression on the CD8 positive cells. And this tumor would be actually likely to respond to the therapy. And so to test this hypothesis, we calculated the PD-1 ratio in the context of the Checkmate 025 trial. And what we saw is that as expected, those patients with a high PD-1 ratio were experiencing a considerably lower, shorter PFS, shorter OS, and lower response rates when treated with nivolumab. And these associations, as you can see, are not seen in patients treated with everolimus. And although I don't have time to show this data here, we were able also to demonstrate that this integrated biomarker, the PD-1 ratio, had improved predictive value when compared to the individual biomarkers. So we are pretty excited about this new data. Actually, these are still unpublished. We hope to publish them very soon. And we are particularly eager now to also evaluate the PD-1 ratio in the context of PD-1 based, anti-PD-1 based combination therapies that we have not yet evaluated. We would expect that probably this biomarker would not be effective maybe for IO-IO combinations because, for instance, anti-TCLA4 might in part function by inhibiting Tregs, but this would be, it's our next step, and we would obviously be interested in validating this hypothesis. My last slide is just to mention that, there are many more opportunities with this type of technologies. We look at relatively small subset of immune cells at the same time, but now we have also technologies that allow us to look at multiple markers in the same tissue sections, and we are adopting highly multiplexing profiling using, for instance, Codex that is allowing us to look at 30 markers in a single tissue section, which is obviously an important advance. And beyond looking at just the composition of the tumor microenvironment, we believe it is very important to look also at the spatial architecture of the tumor microenvironment, because spatial interaction between different cell types, different immune cell types, and spatial interaction between tumor cells and immune cells, as well as cellular neighborhoods, can have not only predictive value, but can definitely inform the immunobiology of these tumors. And I think I'm just going to stop here to acknowledge the people that significantly contributed to the work I presented here today. Many people in my lab, a lot of collaborators are actually here in this room, and also support from the Department of Defense, from the FHCC Kidney Cancer Support, and also support from BMS. And I think I can stop here.
Thank you, Dr. Signoroti, for sharing the unpublished data and the very relevant clinical work. Our next speaker is David Braun, who's going to take us through the promise of spatial transcriptomics, as well as the current limitations associated with it.
Great. Thank you so much for the opportunity to speak to this great group for the Biomarker Symposium this morning. I apologize, I'm not wearing the bow tie. I've got a couple comments about that, so I'll try to fix that for later in the day, but it's early still, so we'll get started. So I'm going to speak today just dovetailing on what Sabina had spoken about, and she's really a pioneer in using multiplex imaging and really be actually leading the charge for a lot of these high dimensional technologies. And so I'm going to try to go through some of the spatial tools that are available and really touch on how they've started to be implemented for RCC specifically. These are my disclosures, not relevant for today. And so when we think of the role of biomarkers, really in my mind, it's twofold. One is, of course, we want to select the right drug for the right patient, but I think equally important is what the resistance biomarkers are telling us. What is it telling us about the biology of the tumor in a way that we might be able to understand mechanism and ultimately therapeutically overcome resistance? And we saw some beautiful examples of that now with PD-1 positive Tregs, which have a clear biological implication. And so the basic idea of how we've been going about this, and I already touched on this so well, is by taking a really complex and heterogeneous microenvironment. And I've used this analogy before, the fruit salad, of really a heterogeneous tumor microenvironment with lots of different cell types, each fruit here representing a different cell type, the responding tumors with the kiwi cells, the resistant tumors with the banana cells. And we put everything in a blender, and that's conventional RNA-seq. And what we get at the end is an average count matrix. We get a gene expression for the average of those cells. And we try to look at the red smoothie versus the slightly different color red smoothie and try to assign a reason why one might be responsive and one might not be. And we can see immediately how this becomes problematic and very difficult. And even with these limitations, there's been outstanding work from the genetic group, from Dr. Powell's and others, using things like consensus NMF based clustering to try to really get at what are the biological underpinnings of these responsive and resistant tumors. But this is a hard thing to do. And this is where high dimensional technologies come in. And so we think of the smoothie as our conventional approach, an average gene expression matrix. We can think of single cell RNA sequencing, the classics or droplet based, as a parts list. We can now tease apart what are the individual components of the fruit, what are the individual pieces of that fruit salad, but it doesn't tell us anything about how they interact with one another. And that's really critical information in situ in the tumor. How are they forming cellular networks and really organizing in the spatial context? And that's really what high dimensional spatial technologies give us, is not just the parts list of what's there in the tumor microenvironment, but really how they're organized together and how that might be really relevant for tumor biology and ultimately response and resistance to therapy. So with that, how is this actually done? And of course, you start with the tumor. Historically, it's been mostly frozen tumor because if you're looking at particularly RNA, that's often unstable and gets fragmented when you fix it in formalin. But there are technologies now that allow you to use FFPE-based approaches as well. You cut it onto a slide and you use one of these many methods that are available now. And so to try to sort of simplify it in my mind, I put this into two big buckets. There's imaging-based approaches and there's sequencing-based approaches. And a lot of these technologies will be familiar by name. And my hope is to try to put it into this context. So a lot of the newer technologies really use in situ hybridization-based approaches. These are things like the 10x Xenium, the nanostring cosmics, and many others, the VisGen system. And the idea here is you have specific probes, for instance, for particular RNA molecules, and you can really get outstanding even subcellular resolution for a large number of transcripts within a cell. On the protein level, we've seen cyclic imaging-based approaches, things like Codex or rebranded as PhenoCycler, cyclic immunofluorescence or CySIF, where the idea is you stain with a limited panel of markers, similar to sort of multiplex IF, but that you can really cycle through by either cleaving or bleaching the fluorescent molecule. You can cycle through many of these and get to high dimensions, 30 markers, 40 markers, even 100 markers. Those are the imaging-based approaches. An alternative is spatial transcriptomics, really sequencing-based approaches. And there's a couple main technologies here. One is deterministic barcoding. The idea here is using, it's essentially a microfluidic system, but to divide the tumor tissue into tiles where you can flow in nucleic acid barcodes in the rows. And those are nucleic acid barcodes that you know. You can do the same at the columns. And now each XY spot has a specific barcode that you know about. And so you can then go about doing your standard RNA-seq or more advanced epigenetic profiling as well, and map it back to an XY coordinate. This is DBIT-seq and was developed by Rong Fan at Yale. And then there's lots of approaches that are capture array-based approaches where you essentially have a lot of beads or capture spots that you are indexed, so you know exactly their XY position, and it can capture the RNA from the tissue. So these are things like the 10x Visium, the traditional system, and Fei Chen's SlideSeq, which was developed here in Boston at the Broad. So this is the overview of technologies. How is this actually being used in kidney cancer? So I'll give a couple of highlights, a couple of quick examples. The first is from the Friedman group, who've really been world leaders, I would say, in understanding the immune contexture of kidney cancer. And they used their first approach was using the Visium system, and was to try to understand what are some transcriptional spatial biomarkers and also biology that might underlie response to immunotherapy. And so looking at just a basic H&E, we can immediately see maybe some lymphoid clusters that could potentially represent tertiary lymphoid structures, these structures that can exist in kidney cancer and many others that are sites of antigen presentation, but also potentially antibody formation. And looking at the Visium, these are each individual pixel here represents, it's not quite one cell, so it's not single cell, but a cluster of cells. It's about 55 microns, so probably around 5 to 10 cells total. We can see what are the transcriptomic profiles in each of those little pixels. And what we can see is a clear TLS signature underlying those lymphoid aggregates, particularly driven by expression of IgG. And when subsequent tumor samples were stained for IgG, there was also a notable association between high IgG and essentially improved clinical outcomes. This is particularly with nivolumab plus ipilimumab. So an early example of how we might be able to utilize these high-dimensional spatial tools in biomarker discovery. Moving on to another spatial transcriptomic approach. This is work that we've done in collaboration with Fei Chen's group at the Broad using SlideSeq. So these are much, much smaller beads. These are about 10 micron beads arrayed on a slide. And we can see, first of all, the H&E images. And then we can actually understand this is a resistant RCC MET, resistant to nivolumab specifically, that then went to the lung. And we can see normal lung tissue. We can see the tumor tissue and clearly the boundary. But each of these individual dots represents one cell, and we can really understand cell identity from the tumor cell side and understanding different tumor cell populations, and then comprehensively understanding the immune infiltration as well. Now, the advantage of spatial transcriptomics is it allows us to link multiple axes, not just what is cell phenotype, but what is their relative spatial localization, and even what is their TCR clonality, what is their TCR family represent. And so we can actually look at T cell receptor families, clonotypes, and see ones that are enriched over here or depleted within tumors. And then we can actually integrate all of that information together. And this is a signature of poor response to immunotherapy that was developed actually in a different context in melanoma, and actually see there's a spatial context to that signature. It's not that there's a universal poor response to immunotherapy signature. It really depends where you are in the tumor, highlighting the need to really dissect the spatial localization and spatial biology of RCC. So some advantages of these sequencing-based approaches, they are a little bit more unbiased, I would say. They are typically, I would say, whole transcriptome, but that's certainly with limitations. And it allows you to potentially do things well beyond just protein. I mentioned things like TCRs, but also we can imagine epigenetic approaches as well, epigenetic profiling within space. Limitations, they're not quite single cell. If you have a 55 micron spot, that's definitely more than one cell. Even the 10 micron spots, you often have overlapping cells. So there's a lot of sort of computational challenges before we get to really single cell data. There's often limited in our protein data, And the capture rate is much lower. For conventional RNA-seq, you're capturing maybe 20 to 30,000 genes. It's an order of magnitude less for droplet-based sequencing and probably an order of magnitude less than that for these spatial approaches. Briefly touching on imaging-based approaches in the last minute, this is still a developing area, and we've worked with Koya and partnered with them and with Dr. Signorelli's lab as well to really look at how this technology can be used in RCC. And I think what has stood out to me is the incredible structural information that you can get from this. So this is a whole slide tumor image of an RCC, and we can see different architectural features, and zooming in, we really get tremendous resolution. I would say far better than we get with any spatial transcriptomic approach, and might allow us to really understand the relationship between different cell populations and truly understand cellular neighborhoods. Here we're looking at certain structural markers and endothelial markers, but we can do the same on the immune side, looking at CD3 infiltration, so T cell infiltration, but also B cells, and really clearly uncover pockets of tertiary lymphoid structures. And so this is a really, I think, exciting technology to allow us to understand not just the profile of what's there, but what is the spatial biology of these RCC tumors. So these are the advantages of these imaging-based approaches, really high resolution, I think allow us to discover cell neighborhoods. There's lots of technical limitations, including cell segmentation, and it's often not nearly as high dimensional as the sequencing-based approaches. So how do we finally implement this in the clinic? Well, I think as Dr. Signorelli mentioned, this is not something where I would routinely do for every patient. It's not multiplex IF, but I think it's a really good discovery-based tool. And so the sort of paradigm we'd put forward is that for a subset of patients, a limited number of patients, we really perform this high dimensional type of analysis, single cell RNA sequencing, spatial-based approaches, and really generate our hypotheses that way, and then use much more conventional tools like multiplex immunofluorescence to then validate in much larger cohorts of patients. So to briefly summarize, I think high dimensional spatial tools are really a next wave of technologies that are really going to impact biomarkers within RCC. It's going to allow us not to just understand phenotypes, but to understand really cell neighborhoods and spatial interactions. There are still lots and lots of barriers, many technical ones, which I sort of skimmed over today, and they're often expensive technologies, so certainly financial limitations as well. And I think for the time being, they're really best suited as discovery tools for clinical samples, things that allow us to generate hypotheses that we can validate from there. With that, lots of people to thank, including many collaborators, many of whom are in this room, and thank you so much for your attention.
Thank you, David, in dissecting everything in like 10 minutes. And we're going to have a break, by the way, at 8:30, and we're going to bring that monitor here for the speakers. So again, KidneyCAN and KCRS is all about collaboration and breaking those walls. Having said so, partners in the search for curing kidney cancer are industry. There is no way we can have it different. And for that, and working on a biomarker, I want to introduce my good friend, Tim Showalter from Artera, to tell us a bit about the AI guiding development of biomarker in renal cell. You may have seen their work, their elegant work in prostate cancer during ASCO and ASCO GU, and hopefully they're going to take this to kidney cancer.
Well, thank you for that introduction, and I can assure you that we do plan to bring this work to kidney cancer, and we're really excited to do so and excited to have the chance to speak here today. So my background is a radiation oncologist. I'm still part-time faculty in practice at the University of Virginia. My primary role is to lead the clinical development team at Artera. So I'd like to talk a little bit about our plans in renal cell carcinoma, and I think where we can have a clear impact. And share with you a little bit of our timeline in that area. Just to preface it, I will show some prostate cancer slides. As Tony shared, most of our early science has been in that space. So I'll keep it simple because I know the goal is to focus on kidney cancer today. So just to introduce us as a company, we are a company that was co-founded by a medical AI scientist, Andrea Steva, and a GU radiation oncologist and translational researcher, Felix Feng. Say what distinguishes our company, which has been around for about 2 years, is that we do have that mix of life sciences, AI, and academic inquiry. And so we work primarily with a very collaborative structure. As Tony mentioned, we have highlighted much of our prostate cancer research at ASCO GU and ASCO over the past couple of years. We have trained and validated our first test in prostate cancer, primarily using data sets from NRG Oncology for landmark radiation therapy trials. And that prostate cancer test is currently on NCCN guidelines and clinically available. My role is to help build tools to serve patients with other types of cancer. So we work collaboratively and we have a pretty broad pipeline where we want to have an impact, and renal cell carcinoma is definitely a major priority for us. Just to clarify where we stand, oops, sorry, let me go back. In terms of the digital pathology landscape, there are a lot of companies. It's a really hot area. Of course, we're all using ChatGPT and exploring AI. So both digital pathology and AI are really dynamic areas right now. We stand in the area of really focusing on predicting prognosis and benefit from therapy, so predictive signatures as well. And unlike many other digital pathology companies, we're not really focused on pathology workflow or being part of the initial diagnosis or cancer detection. We view our role as enabling precision medicine that really scales and can make a broad impact for specific treatment decisions and can touch more cancer patients globally. So we work primarily with H&E stained biopsy and surgical slides. Very often we're working with clinical trial data sets or data sets from institutional collaborators. And our goal is to deliver tools that are based on whole slide images from these samples can provide prognostic and predictive insights that have a clinical impact. We work with large data sets. That's an important advantage for robustness to make sure that our findings are not dependent upon specific staining characteristics at a single institution. The advantage of this technology is that we have a short turnaround time, and that goes for both our research and development as well as for clinical deployment over time. We don't consume a tissue in our research process, so it's often, unlike many other tools for biomarker development, we're not depleting precious resources from clinical trials, but we're often creating an archive and resource for additional discovery by academic collaborators in the future. This is a picture of our architecture for prostate cancer. We call our overall architecture multimodal AI. There are lots of different types of information that can be used for multimodal AI. We use whole slide images and clinical data. So what's represented here is our architecture for our prostate cancer biopsy test. We just to give you a little bit of the value add for clinical variables, the PSA is included in this model, and that's information that's not otherwise available on a slide. So it does have a significant influence on model performance. We also digitize available biopsy samples for whole slide images and stitch them together into a single image quilt that the computer vision AI then trains on to identify relevant tissue patches. So we use a self-supervised learning approach. And then part of the training process for outcome prediction is identifying the key tissue patches that are and features that are predicting a clinical outcome. So that's my clinician's version of the AI approach. But I think the main things to know here are that we work with unannotated slides. So these are clean biopsy slides in our initial training and validation set for prostate cancer. And I'll show you results from that. These were often like 20-year-old slides with a limited number of them. We view that as a workflow advantage, and we are committed to self-supervised learning currently in our approach. It does lay the groundwork in the future for additional discovery. So we think that spatial analysis coupled with this approach might unlock some new discoveries in the future as well. So just a couple slides on what we've done in prostate cancer to give you a sense of how this technology can be used and the sort of impact that we plan to make in renal cell carcinoma. So for our initial work in prostate cancer, we partnered with NRG Oncology using samples from 5 randomized controlled trials. And we had about a 70% biospecimen availability rate for those trials. So we combined a limited set of clinical variables that are shown here. So Gleason score, T-stage, PSA, and age. And we divided the cohort into an 80% training set and a 20% validation set. We trained algorithms to predict for separate clinical outcomes, so biochemical failure, distant metastasis, PCSM, and overall survival. Cutting straight to model performance, I'll share with you that we benchmark our model performance to NCCN risk group clinical factors, and we demonstrated across the clinical endpoints an improvement in performance compared to clinical factors alone. And so we consider that our pre-specified performance metric for this. We've since validated on around 8 additional trials, and publications are forthcoming for that. We've done a look at algorithmic fairness over time. So Mac Roach last year at the main ASCO annual meeting presented our work that established that model performance is similar in African-American patients versus non-African-American patients in the RTOG trials. Another value of using multi-site cooperative group trial data for training and development. We've also applied a similar framework with some slight modification to develop a predictive signature for benefit of hormone therapy. So this study is the short-term ADT predictive signature. It's currently part of our prostate cancer test. We also this year had a presentation by Andrew Armstrong at the ASCO annual meeting about our separate classifier for benefit from long-term androgen deprivation therapy. So we, in this approach, divided 4 trials into the training set, and then we held out RTOG 9408, which was a randomized trial of radiation plus or minus short-term androgen deprivation therapy for intermediate risk patients. We use that as the validation set. So to give you a sense of the goal for this, so based on this model, which effectively risk stratifies patients, we were able to identify a majority of patients who we're calling here on the slide biomarker negative, who essentially are less likely to derive a significant benefit. So in general, there's about less than a 1% difference in terms of distant metastasis rates, and a biomarker positive group who derives a much larger benefit. So I think this is a space that is very exciting clinically. As a GU-focused radiation oncologist, I'm constantly having these conversations with patients. So I think having more confidence that the patient is more likely to benefit from short-term androgen deprivation therapy has a lot of strengths. And you can imagine that extending into other clinical situations where your number needed to treat is in a more favorable context. So what are we doing in renal cell carcinoma? So we know that, and others have shown that this overall framework does translate really across cancers. Our SSL model, so the component that analyzes images, benefits from training across diseases. So there's our development cycle shortens over time. We do plan to develop tools in other GU cancers, and renal cell carcinoma is a top priority for us. We currently are beginning research collaborations and collecting data starting from institutional cohorts at many of your colleagues here from across the United States, and then also working with cooperative groups on scientific proposals to explore biomarker development with those data sets as well. We are still building our overall pipeline, but the general summary of what we think we can do is that we do think that we can use this technology for really strong performing prognostic risk stratification, which I think will have direct clinical benefit for patient care. We're planning to be able to develop a model that predicts risk of distant metastasis after nephrectomy. We also think this is really a promising technology for identifying sets of patients who are more likely to benefit from adjuvant therapy. To give you a sense of our timeline, we are ongoing in that process of collecting data, scientific proposal work with our collaborators, and getting that work up and running. We expect to begin formal model development and analysis by the fall or winter of this year. Our development cycles are typically 2 to 3 months. So we expect by next year, we'll begin taking a look at how this overall architecture can perform in terms of predictive purposes. So identifying patients who are more or less likely to benefit from therapy. We're always looking for more collaborators. We're, very academically inclined group. So I guess the call to action is that if there's interest, I'm always happy to have a conversation to see if there's, scientific opportunity there. We're really hoping to make an impact on therapy decisions for renal cell carcinoma patients. So happy to include any interested folks in that. So thank you for your time.
Thank you, Tim. Now across the street from Dana-Farber, my good friend, Dr. Heather Jacine, who has worked tirelessly in radiotheranostics in prostate cancer. But what they say, imitating is the best art, or something around that. So we're trying to get her skills to kidney cancer. She's a nuclear medicine physician by training.
Thank you, Tony. Good morning, everyone. Thanks for inviting me. As Dr. Shweri said, I'm a nuclear medicine physician by training. And so I'm going to talk a little bit about metabolic or molecular imaging agents in kidney cancer. Let me see if I get this right. So these are my disclosures. And I just wanted to start, I don't really need to go over the language, but in imaging, we really talk about have the same biomarker language that you guys have outside of imaging in regards to prognostic markers, predictive markers, integrated biomarkers, where an imaging test might not change the plan, but then an integral biomarker where you make your decision based on the change in that particular marker. And we need to test the imaging biomarkers just the same way that you test your other biomarkers. And so I wanted to really show this slide. There are so many different targets and things in cancer that go awry, and you guys know them better than I do. And this is not a comprehensive wheel, but there is really probably a radio tracer that is out there to interrogate all of those different processes. They can look for specific markers, but they can also look at the downstream effects of those aberrations in the cancer cells. There have really not been a lot of molecular imaging, I think, that's been done in kidney cancer so far. The tracers that have been evaluated, FDG, there's a new one, girentuximab, PSMA a little bit, cestimibie. The one that's clearly missing from this slide is there is several CD8 radio-labeled markers that should be really added here. When you look a little bit further on these radio tracers, really they've been used to detect, there's a fly right in front of me, to detect disease, particularly FDG, PSMA, really to characterize indeterminate masses, and really less so in the space of as prognostic or predictive markers. There are a couple small studies demonstrating that the more FDG uptake that you have in a tumor and the more PSMA uptake, that's predictive or prognostic for bad prognostic features. And there are a very few small studies looking at FDG changes with sunitinib, but the studies are very small and they're mixed populations. So I would be hard pressed to stand here to try to convince you that that would be the answer. So what I really wanted to do in these 10 minutes was show you from experiences from other malignancies, how molecular imaging could potentially be used as you're developing biomarkers, clinical trials, and where molecular imaging can help. So the majority of these examples are in breast cancer. You can use the molecular imaging for target characterization to optimize therapy. And so this is an example of work. There's a lot of work being done out of the University of Washington in Seattle, looking at FES PET imaging, which is estrogen receptor imaging. And here what they've shown, I don't think I have a laser, but in the top row, what they've done is they've identified really 3 groups of patients. So patients who have, and that's the blue line, the top row is FES. So patients have low FES, so low estrogen receptors, and then they have low FDG uptake. And so those patients don't do, they have high FES uptake and low FDG. Those patients respond very well to endocrine therapy. Patients who have high FDG uptake but low FES uptake, they don't respond very well to endocrine therapy. And then there are patients who are intermediate, high FDG and high FES who do in between. So they're currently designing clinical trials now using FES and FDG to determine which patients should go on to get endocrine therapy. The next example is radio-labeled pertuzumab, so a HER2-targeted agent. This study was done in patients who their primary tumor was HER2 negative. So by default, those patients are usually not going on to get HER2-targeted therapy. But in the very top image, you can see that this patient's metastases were in fact expressing HER2 and were positive on the pertuzumab scan. The bottom two images, the middle row shows FDG uptake in those HER2 positive tumors. And because of the scan on the top, the patient had dual targeted HER2 therapy added to her chemotherapy regimen, and she subsequently had an excellent response. So here it's tumor characterization, and one of the benefits of the molecular imaging is that you're not only relying on a single biopsy, but you're really getting in vivo examination of the entire tumor burden at a time. So the next place where you can use molecular imaging is really also as a pharmacodynamic marker. And you can actually use these with the goal of getting the marker to clinical trial, but I'll also show you an example where it was used in clinical trial development, not with the idea to get into clinic. So these are the results of a study, again, in HER2 positive breast cancer, where they were going to give dual HER2 targeted therapy. They did a baseline FDG PET CT scan, and then after just 15 days of therapy, they did a repeat PET scan, and the endpoint of this study was to predict PCR, which is very prognostic in this patient's group. And what you can see here is that you divided the patients into patients who did not have a PCR and those who do had a PCR. And really the main outcome was if you did not drop your SUV by 40% at that day 15 with a 91% negative predictive value, you were unlikely to have a PCR and may need additional therapy. So currently, this is a cooperative group study that I'm working with Roisin Connolly on, but we're going to try and validate that marker of 40% threshold in this patient population. And then the subsequent idea is that we can design really integral imaging biomarkers where based on that change of SUV at that 15 days, so very early on, we would change therapy to try and be able to get somebody to a PCR. And then here is an example from the group of Sloan Kettering where they used molecular imaging as a pharmacodynamic marker in a phase 1 study to look for estrogen, again with this estrogen receptor imaging to look at in a dose finding study to help them decide what the recommended phase 2 dose would be for subsequent studies. So here they defined that if you had 90% suppression of estrogen receptors after starting the drug therapy, that would be considered, that was the endpoint they were looking for. So you can see at the lower dose levels that most of the patients had not achieved the receptor occupancy that they were looking for. So that was not high enough doses. And then you can see at the upper level of doses that was achieved. And so here the idea is that you have a visual way to look at receptor occupancy before waiting for patients to have toxicity, and that hopefully you could spare them that and get to a drug dose that would be or safe and efficacious quicker than you would waiting for adverse events to occur. And then finally, this was really an interesting study. This was a non-small cell lung cancer. This was an example of a co-clinical trial that was performed. So patients were receiving, with non-small cell lung cancer, they were receiving docetaxel, and the investigative arm was docetaxel plus selumetinib. And what they did was they ran PDX models from the patients enrolled on the trials at the same time. They did FDG PET imaging in the animals, and they found found that there were really 3 groups of animals. 2 of the animals had responses on an early PET scan done just 24 hours after starting the drug. The 3rd group of animals did not have the same change in their FDG. Based on that, they went back to the lab and found different mutation in that 3rd group of animals. And then based on that, they went back to the patient studies and were able to study the patient tumors to enrich the clinical trial, the arms. And because of that, the overall response rate in the trial was a little bit higher because they got rid of, or they excluded patients who were less likely to respond. And that helped the drug get to approval much quicker than otherwise probably would. So just in these 10 minutes, I think my goal was really the big goal was really to try and get everyone to think about imaging beyond just looking for a response, which is how we typically, I think of imaging, particularly molecular imaging, but that you can really use it for tumor characterization. You can use it ultimately then to help therapy optimization. You can use it as a pharmacodynamic marker in trials that with the idea that it can be used in the future for clinic, or you can use it as a pharmacodynamic marker in trials for drug development. That example from Sloan Kettering, they didn't have the idea that that was then going to be used in clinic. It was really just to help them find the dose, and the same with the clinical trial. And really, if you can think about kind of the process and the biomarker that you're looking at, and then really match it to the best imaging test, I think there's a lot of potential for molecular imaging to help in the development of what you guys are doing for kidney cancer. Thank you.
Thank you, Dr. JC. Our next speaker is Hediye Ibrahimi, who's going to walk us through CT-based radiomics tools for predicting genomic alterations in RCC.
Good morning, everyone. On behalf of my co-authors, I would like to thank KCRS Scientific Program for the opportunity to present our study on CT-based radiomic model for prediction of genomic alterations in patients with renal cell carcinoma. First of all, I would like to define what do we mean by radiomics and radiogenomics. Radiomics refers to extraction of qualitative and quantitative data from clinical images and translate those features to support our clinical decision-making. And by radiogenomics studies, we aim to correlate the clinical images features to genomic alterations in our patients. Previous studies showed compelling evidence for this approach in various cancers, including glioblastoma and lung cancer. And as substantial proportion of our patients with clear cell renal cell carcinoma, the most common histologic subtype of RCC has alterations in VHL gene, and also other alterations in PBRM1 and SETD2 has correlation with patients' prognosis. We felt that this approach may play a role in our field too. Therefore, we aim to assess the role of radiogenomics in predicting genomic alterations in patients with RCC. In this study, we identified 14 patients with genomic tissue genomic testing from CT-guided biopsy. We used the genomic testing using GemExtra assay containing both whole exome and transcriptome sequencing. And afterward, we locate the biopsy location site from pre-biopsy CT images. After assessing the radiomics features, we built AI-based models to predict PBRM1, VHL, and SETD2 gene alterations. And at the end, we try to assess the predictive performance of our models. As shown here, we included 14 patients in our cohort, out of which 10 were males. The most common histologic subtype within our patients cohort were clear cells. We also have 3 patients with papillary histology too. The most common location for biopsy was lung tissue. And the most common alterations within our patient populations was PBRM1 followed by VHL and SETD2. As you can see, the PBRM1 alterations was predicted with highest performance using support vector machine classifier, followed by SETD2 alterations by logistic regression classifier and VHL using support vector machine classifier. Notably, all three models had the high sensitivity to predict genomic alterations. In conclusion, we saw that support vector machine classifier and logistic regression classifier could predict genomic alterations, including PPRM1, SETD2, and VHL mutations with high accuracy in patients with renal cell carcinoma. Therefore, we feel that these models may assist us in identifying alterations that has prognostic values in our patients. Of course, our study has some limitations, including a small sample size and elapsed time between genomic testing and imaging that we use in our study. So we feel that further extensive studies are needed to evaluate other models and validate them. And at the end, I would like to thank our exceptional research team at City of Hope and my mentor, Dr. Pal. And thank you so much for your attention.
Thank you, Dr. Ibrahimi. Our last talk is from Dr. Renee Mariah Saudi, and she's going to talk about circulating and intratumoral immune determinants of response to atezolizumab and bevacizumab in patients with sarcomatoid RCC.
Good morning, everyone. Thank you for the opportunity to present our work today. Non-clear cell renal cell carcinoma account for 20 to 25% of all kidney cancers. However, all large trials have excluded almost a patient with non-clear cell renal cell carcinoma, which created an area of unmet clinical need. Our objective from there was to understand the intratumoral and circulating markers that impact the outcomes to atezolizumab and bevacizumab in patients with non-clear cell carcinoma. So how did we do this? A phase 2 trial led by McGregor, McKay, Braun, and colleagues evaluated the anti-PGL1 atezolizumab and the monoclonal VEGF antibody bevacizumab in patients with non-clear cell RCC or with more than 20% sarcomatoid RCC. This study showed an overall response rate of 33% in the whole cohort and of 26 to 50% in subgroups. Blood and tissue were collected at baseline, and blood was collected again on treatment. We performed flow cytometry, cytokine multiplex immunoassay to quantify the circulating cytokines, and on tissues, we performed IHC and multiplex immunofluorescence. Baseline characteristics, clinical characteristics, and treatment-related outcomes were collected from the trial. Clinical benefit was defined as the sum of objective response, so CR or PR, or stable disease with tumor shrinkage and PFS of more than 6 months. Patients with progressive disease and PFS of less than 3 months were characterized as having no clinical benefit. All other patients were categorized in the intermediate clinical benefit group. Let's start by looking at the circulating cytokines. We performed the Pearson correlation, and the clustering of the correlation matrix revealed an inflammatory module that consisted of 5 highly inflammatory cytokines that were correlated with each other. 4 of these 5 cytokines at high levels were associated with worse PFS. From there, we decided to calculate the average score of these cytokines and called it the systemic inflammation score. Now, how is this systemic inflammation score, or SIS, associated with clinical characteristics and outcomes? It largely differed between IMGC subgroups, with the poor IMGC group having the highest SIS. And this makes sense because the IMGC score does rely on some inflammatory correlates like anemia, neutrophilia, and thrombocytosis. SIS also differed between clinical benefit groups, with the non-clinical benefit group having the highest SIS. When dichotomized at different thresholds, here at the 25th percentile, patients with the higher SIS had worse PFS. Now, after looking at these inflammatory cytokines and in the context of an IO-VEGF treatment in non-clear cell carcinoma, does circulating VEGF play a role in response to treatment? Patients with higher baseline VEGF had no clinical benefit from treatment. As a continuous variable and dichotomized here at median, patients with higher VEGF levels at baseline had worse PFS. After looking at the circulating biomarkers, let's look at the intratumoral biomarkers, notably the intratumoral cells. Are they associated with outcome? We performed a spatial phenotyping at the Seniority Lab and looked at antigen experiment marker, PD-1 at the bottom, and terminal exhaustion marker, either TIM3 or LAG3 in intratumoral CD8 T cells. We can see a small clustering of tumors with non-sarcomasoid component. Because of the small number of samples here, we can't draw any definitive conclusion when looking at each histology. However, across the whole cohort, patients with a higher percentage of intratumoral terminally exhausted CD8 T cells had the worst PFS. This is the first study to characterize these biomarkers in non-clear cell RCC. To conclude, our study revealed some circulating and intratumoral markers that were associated with worse outcomes in patients with non-clear cell RCC, based on inflammatory levels, high VEGF levels, and high intratumoral terminally exhausted CD8 T cells. Our future steps would be to validate in an independent cohort to look at these biomarkers in regard to adverse events and to investigate each type of non-clear cell RCC, as we know that each of these diseases is very different. 5 minutes is too short, so please feel free to read our paper that was recently published in Cancer Immunology Research. I would like to thank first and foremost the patients and their family. This work was done with them and for them. My mentors, Dr. Schwery and Dr. Braun.
I'm going to take some questions and feel free, please. I want to welcome Dr. Bex and definitely Dr. Pal, who just landed. You know, I don't think Monty slept at all. So any questions after these 7 very short talks that give you just one part about biomarker? That's the technology part, waiting for the clinical part with Dr. Powles. If there is no Axel, first question. Dr. Braun.
That the technique can also be used to show T cell clonality. I mean, normally it's done by single cell sequencing, but some have said that you might use the beta chain. Is that possible?
Yeah. Right. David, you want to come here? I have the mic for you. I want to expose you more now without a bow tie.
So the short answer is yes. So once you have the RNA, it's technically challenging to amplify actually not just the beta sequence, but the alpha sequence as well. And so the paper that I mentioned from Immunity last year, it did that. It developed this platform, and this is largely driven by Fei Chen's group called Slide TCR-seq. And so you can actually understand spatial relationships of these clonotypes. So the short answer is yeah, that's the next emerging thing, and you can definitely get even paired alpha beta sequences for a spot. Obviously not for an individual cell, but at least for a spot.
One thing, David, it's extremely expensive. That's why we start by a couple of cases and go to more mainstream. I hope that mainstream is RNA-seq, not the IF, because that's not mainstream what Sabina does. It's very also expensive, but that's really expensive. Hopefully this catches up with the Moore law, and because it's almost like impossible to do beyond 5-10 cases sometimes in our budget.
Absolutely. But understanding, I think, the clonotypes in space where they are particularly enriched clonotypes relative to tumor cells in different pockets is I think now possible with this.
Yeah, well, you can stay on stage. Dr. Atkins.
Thank you. So I have a question for Sabina. I just want to have her expand a little bit more on what she presented. So actually 2 questions. The first one is, do you think high PD-1 on Tregs could explain hyperprogression that's been seen in some tumors and do we possibly maybe see that in kidney cancer? And the second question is, when you looked at your ratio, you looked at 0.25, which is a second line study. Were you looking at primary specimens and then trying to relate those to what was happening in the second line when those patients had, and those tumors had already been exposed to VEGF? And do you think that this, there's a better way of doing it, I guess?
Thanks, Mike, for these questions. So first of all, in terms of hyperprogression, PD-1 expression Tregs has been associated in different tumor types to hyperprogression. We do not have clinical data with the hyperprogression in the context of the CheckMate 025 trial, but what I can say, and I didn't have time to point this out in the presentation, is that actually there is a the association that we see is there's a very strong association with survival that we don't see sometimes with other biomarkers. And we think that this could be explained by the fact that those tumors that have high levels of PD-1 on the Tregs actually become more aggressive after treatment, and they might progress more quickly and might be also less responsive to further therapies down the line. So there are some indirect data that seems to support that even in clear cell RCC, these PD-1 positive Tregs might drive a very aggressive progression of the therapy. The second question, yes, we are very aware of all the limitations in studying. So in the context of the CheckMate 025 trial, we studied mostly primary tumors that were resected prior the VEGF targeted therapies. So these analyses have some limitations. And as you know, we are planning now to perform studies in the context of the HCRN trial that you basically conducted with the intent to really look at tumors that were resected in treatment-naive patients. What I can say is that although we have these limitations with the CheckMate 025 trial, we have seen the other biomarker, the CD8 positive cells expressing PD-1 but not in TRINLAT3, actually was identified initially in the CheckMate 010 and CheckMate 025, and with the same limitations that we just mentioned, but we were able to actually validate it in the first line setting. So maybe in some respects, those primary tumors that were resected prior to VEGF targeted therapies are still informative with respect to responses to immunotherapy in the second line.
So one thing before Hans' question, what we were trying to look at, Mike, especially in a clinical trial that had sunitinib or VEGF TKI as control and an IO, looking maybe unidimensionally, which is naive, at the PD-1 on Treg, because here potentially with Tregs, it's like Mike Pence fly, with Treg, here potentially sunitinib affect favorably PD-1 on Treg, and you will see something, while potentially with IO only, this could be associated with PD as best response, which is the closest to hyperprogression we can get. Hans?
So that's a very interesting topic, obviously. Will you have the chance to look at the CheckMate 214 data sets? CTLA-4 inhibition affects Tregs in various degrees, I guess, on the agent, etc. But I think that would be a very interesting data set to look at that.
Follow-up question, if you don't mind. Follow-up question, if you don't mind, is due to the prevalence of these PD-1 positive Tregs in CPI experienced CPI naive patients, and also co-expression of other inhibitory molecules, including TIGIT.
So I'm going to answer Hans' question first. So in terms of 214, yes, we are collaborating with our with Dr. Saurabh Gupta and others at BMS, and we are in the process of really looking at this clinical trial, because our prediction could be that this PD-1 biomarker on Tregs might not be associated with the resistance in that context for the reasons that you mentioned, that obviously CTLA-4 targets also the Tregs, but we'll have to see the results. We don't have them yet. So in terms of prevalence, definitely the prevalence, I mean, I don't know how to define. It's like I don't have the data and the quantification. I'm happy to share those. Hopefully this data will be published soon. They're not highly prevalent, but there are tumors in which there is a high percentage of Tregs that do express PD-1, definitely. And we have not explored the expression of TIGIT in these cells, but this is another marker that we are actually starting to investigate right now.
Okay, and what about its prevalence in CPI experience versus CPI naive patients? So post CPI therapy, typically
almost never have.
Unfortunately, this is a major issue because we do not have, so we haven't been able to collect this data so far. Yes, definitely.
Well, I think Marouk is the lead translational scientist for many trials we were involved in from the time that David McDermott here, our spore leader. But one is CONTACT-3, the extremely highly negative study in renal cell, which, you know, you have to ask yourself why it's like that. And it's a unique opportunity, at least from clinical endpoint, to look at post-CPI experience. I think the tumor tissue will probably be from, you know, unexperienced CPI and inexperienced patient. Any questions? If not, I have a question for Tim. Really fascinated by what AI captures, and you know, it seems real, despite we don't understand what AI, you know, and the computer picks that we don't, I'm sure, which is kind of scary. But one application is not predictive as much as prognostic, especially in adjuvant treatment, because in adjuvant treatment, whether it's renal cell or anything else, we overtreat. Do you think because your main problem in adjuvant is ctDNA, because, you know, if you detect this is going to be more powerful than anything, because this is direct evidence. What you provide is indirect evidence, something. Do you think you may have to integrate with ctDNA when it's coming and you provide an edge over it?
Yeah, absolutely. I mean, that's a great question. I mean, I think they're definitely complementary. I think that our technology can be used upfront, and then ctDNA maybe you know have longer term benefits. Just as an example from prostate cancer, but our prognostic algorithm was shown to be predictive for benefit from apalutamide intensification for non-metastatic castrate-refractory disease. So that's the same algorithm we developed in localized disease. So it just shows we presented that at ASCO, we had a poster on that. I think that that sort of concept, so like having effective risk stratification with a prognostic algorithm in RCC may be really helpful for, you know, identifying subgroups of patients who are more likely to benefit from adjuvant therapy.
Thank you.